This is the second time I speak in front of a Finnish audience after your invitation last year to Finland. Still very good memories of that, jumping into the Baltic Sea and stuff like that. Really, yeah, wonderful memories. And yeah, thank you again for hosting that and for inviting me. So today I'd like to talk about competencies of psychedelic therapists. And I was told I have an hour for the talk, plus an hour of discussion. I think I don't need quite as much time for the talk. Maybe I need 45 minutes or so. Maybe we have more time for discussion then. And yeah, the title of the talk is perhaps a bit asking a question as if I could give a definitive answer. Of course, this is a disclaimer, yeah, that I'm not, yeah, I'm trying rather than saying this is how it is and this is how it should be. I'm trying to convey our ideas. They're the ideas behind what we do in the training that we do. And of course, there can be other views of this and other ideas. Yeah. So today, I'd like to give a bit of a background of this talk. Why do we need this kind of discussion? I will give a definition of psychedelic therapy and talk a bit about special features and special problems. And then I would like to take some time to present the 12 APT outcomes or key competencies of psychedelic therapists that we formulated as a kind of the basis of our training. And yeah, I brought some kind of case examples also to illustrate why these competences are necessary. Yeah, and then I will also give a bit more information about the APT program. Henry told me that it would be of interest also to talk a bit about the admission criteria and things like that. So I brought a bit about that as well. Yeah, so why are well-trained psychedelic therapists needed? First of all, there's growing numbers of clinical studies with classical psychedelics. So this is already a few months old, but in February 24, there were 84 studies already with psilocybin. 4 of them were phase 3 studies. Other substances are long behind. There are also, of course, a few more substances now, not only these 3 here. Of course, therapists are needed, yeah, for these studies, and these studies are also a great way to build competencies in psychedelic therapy. Then, of course, outside of clinical studies, yeah, there are in some countries there are special regulations with, for instance, MDMA or classical psychedelics. In Australia, psychiatrists can already work with psilocybin and MDMA. In Switzerland, yeah, people can have can ask for a special license or permit to treat individual patients with these drugs. Yeah, other countries are in similar situations. In Germany, we're now working on that too, on a compassionate use program for psilocybin. This could be a reality in the next few months. And then, of course, there are treatments with other substances that are already regulated, such as ketamine. So ketamine augmented psychotherapy is something that we also do here at Mainz Clinical Partner, the VIT Clinic. Yeah, and not least non-pharmacological induction methods, breath work. And then apart from that, there is also an overall increase in the use of psychedelics across populations, and there's also a need for therapists to be informed about psychedelic experiences, harm reduction, and yeah, we also at the clinic where I work, we also treat people who have used psychedelics outside of the therapeutic context. Yeah, who provides training? So as a German, I start with the German-speaking countries. So we do our training. There's also the SAPT, the Swiss Physicians Association for Psycholytic Therapy. They've done this for a bit longer. There are less comprehensive courses also offered by smaller providers. And internationally, there's also a huge number of different providers of therapy trainings. There's like state universities, university hospitals. They do courses. There are private universities such as the CIIS. non-profit organizations such as MAPS, pharma companies, they train their therapists, of course. Commercial providers of various courses also. So there's no uniform standard. Of course, there's no official regulation or certification, no legal certification anywhere for psychedelic therapy trainings. So it doesn't come as a surprise that all these different trainings that we see out there, they have no uniform standards with regard to things like admission criteria, the duration of the training. Yeah, this is from hours to years. The reference systems, yeah. So is there an orientation to evidence in medicine and psychotherapy, or is the orientation more to alternative frameworks? Learning objectives, which is my main topic today, but also quite different in different trainings. Yeah, the contents, the formats. Some trainings are on-site, online, hybrid trainings, different certificates, and so on. Yeah. So if you look at the literature regarding psychedelic or competencies in psychedelic therapy, you will not find much. There is very limited literature, especially empirical literature is lacking. A few proposals have been made, comprehensive proposals for what competencies psychedelic therapists need. This is one example here by Janice Phelps, director of the CIIS, the California Institute of Integral Studies. This is a good example of previous proposals, because I think so. One feature that these proposals share is often that there's little reference to more general medical and psychotherapeutic competencies. If there is a reference to psychotherapy, then it's usually to therapy schools like psychoanalysis, ACT, or other systems of psychotherapy. And usually there's no reference to kind of psychotherapy research and things like that, trans-theoretical models of psychotherapy. There is often a focus on relatively special and narrowly defined phenomena with assumed therapeutic significance, such as mystical experience or experiences of being reborn, things like the inner healing intelligence. These are often concepts that are also quite idiosyncratic for the psychedelic field. And then there's also often an emphasis on certain special competencies, such as the spiritual intelligence, in this paper here by Janice Phelps. And a strong emphasis on the aspect of self-experience with psychedelic drugs. So I did a little thing here. If you type into Google Scholar psychedelic therapy training, then you will find mostly the first 3 pages of my results at Google Scholar. I understand it's not the same for everyone, but for me, the first 3 pages were mostly papers about self-experience. Yeah? So psychedelics as a training experience for psychedelic therapists. Yeah. Personal psychedelic experience of psychedelic therapists during training. Should it be required, optional, or prohibited? Experiential training in psychedelic therapy, risk-benefit analysis. Is the requirement for first-person experience of psychedelic drugs a justified component? And so on. So there's lots and lots about this topic. And yeah, I think we can all agree that it's an important topic, and that these discussions must be had. I would say probably it's more important not about the question whether or not people should have self-experience, but rather what kind of self-experience is beneficial, or what approach to self-experience. But we're really not there yet. We're really just still discussing here, at least in the research literature. Mostly the question, is it really necessary or not? Which kind of simplifies the problem a bit. Oversimplifies the problem a little bit. So yes, so this is, I think, maybe to just continue there. I don't know, probably most of you have seen this picture or this video. This is from a MAPS clinical trial where 2 therapists sexually abused. At least one of them, a patient here. The therapists are both seen kind of spooning the patient, clear transgressions of psychotherapeutic principles and ethical boundaries, and quite shocking, really, especially even considering that they did all this, although this was videotaped and so on. If you look at this video, it's really quite harrowing, and it really shows that we need more than just experience with psychedelics. Yeah, we need much more. There's a lot of things to consider here, and I will come to speak a bit about the underlying problems here a bit later today. Yeah, another example of current discourses around psychedelic therapy that is relevant is illustrated by this picture here. It's a bit less drastic here, this picture, but you can also see in the background, if you pay attention, you see this Buddha statue, a religious symbol, depending on how you define religion. And this has been discussed in the field, and it also shows something about the understanding of what is done here. Yeah? What is this treatment? Is it psychotherapy? Are we psychotherapists, or are we spiritual teachers or guides or so? Yeah? So this is also a discussion to keep in the back of the mind. Relatedly, the discourse about the role of psychotherapy. So this paper from last year, Goodwin, must psilocybin always assist psychotherapy? So this is really an interesting paper, because Guy Goodwin here is asking the question, or is trying to say that psychotherapy is unnecessary for treatment with psilocybin, and he uses, among other things, his own trial to illustrate that psychotherapy is unnecessary, and that psychological support is not psychotherapy, but it's only a safety measure. And at the same time, the study manual, the training manual for the therapists in that study clearly describes the psychological support model as psychotherapy. So here is a response to this paper from our group. I was also an author of this. Clarifying that treatment with psychedelics, as we see it in current clinical trials, is always psychotherapy, and it should be understood like that. So this is one of the positions that we build our therapist training on, the view that psychedelic therapy is always psychotherapy. This is also, when you look at basic research in psychedelic therapy, it's also clear that the efficacy seems to rely on the same change mechanisms as other psychotherapies. Here's an example showing that the therapeutic alliance, well-researched change mechanism in psychedelic, in general psychotherapy, predicts therapeutic experiences in dosing sessions, and this in turn predicts depression changes. This has been replicated now with psilocybin one time, and also with MDMA. Go a bit further, the relationship is one of 5 general change mechanisms. There's 4 more. This is perhaps a bit complex for today, but I wanted to show this, that we also developed this questionnaire, the general change mechanisms questionnaire, to make standard general change mechanisms of psychotherapy measurable in the context of psychedelic therapy, assuming that it's the same processes in the end that underlie the efficacy of psychedelic therapy and other forms of psychotherapy. So to bring a bit more kind of empiricism to this discussion. Here's a figure from that paper giving a simple understanding of how a psychotherapeutic understanding of psychedelic therapy. We give someone a drug, then they have a psychedelic experience. The psychedelic experience mediates the longer-term outcomes. The experience can be understood in terms of psychotherapeutic change mechanisms. This could be a whole talk on its own. I talked about it last year in Finland about what these change mechanisms mean. Probably we can maybe go a bit, if you're interested in the discussion later, we can talk about it a bit more. And then the task of the psychedelic therapist is really to establish a context. And that goes for the immediate context, or colloquially speaking, set and setting, as well as the kind of more overarching, superordinate context. So the therapist must, or the therapeutic team must establish a psychological and social context in which therapeutic experiences become more likely, and in which therapeutic experiences can be integrated in a way that leads to beneficial longer-term outcomes. This is a very simple psychotherapeutic understanding of psychedelic therapy. So here they are again, the 5 change mechanisms. We want to take a biopsychosocial perspective. It's not only the psychotherapeutic change mechanisms. Of course, there's also a biological perspective on psychedelic therapy. We're using pharmacological agents. These are just 3 hot topics in kind of the biologically oriented psychedelic research of measures of enhanced context sensitivity and adaptability that you can see in mouse models, in laboratory settings, and these are not competing models, but they're really should be understood as complementary models in a biopsychosocial perspective. Yeah. Another piece of background is, of course, there are established practices and recommendations and even emerging guidelines already for psychedelic therapy. Here's the paper by Matt Johnson, Safety Guidelines for Research. There are all kinds of therapy manuals. This is an example from our episode study. I was also an author of this manual. There are, I don't know how many have been published, but there are a lot of manuals available, and they have lots of overlap and also some differences between them. And they're also a good orientation about how psychedelic therapy could look like. And we can derive competencies, of course, from these manuals. Yeah, and then there are already emerging guidelines also. This is from the Swiss Interest Group for Psychedelic Assisted, it should be psychotherapy. And then there are also published more specific models, like the Montreal model, kind of psychedelic augmented therapy model with ketamine, that is very well spelled out. And this can also be taken as a basis for formulating competencies of therapists. Yeah, a bit about our own experience. So the Mind Foundation has a clinical partner, the Ovid Clinic, that's just down the road. And at the Ovid Clinic, we treat patients with ketamine augmented psychotherapy, not just ketamine infusions that you see here, but these infusions, they take place in a psychotherapeutic setting. And the ketamine induced altered state of consciousness is not treated as a side effect, as this is actually the case, right? In many clinics, ketamine is used with a pure biomedical model that ignores or disregards the altered states that are induced by ketamine. And here it's different. Of course, we have a biopsychosocial model, and we use the plasticity enhancing effects of ketamine. But we primarily use it to induce and deepen psychotherapeutic processes. We also are a study center for some clinical studies here, also with classical psychedelics. And then a lot of our experience also comes from the episode study, which is a phase 2 study, 2 centers in Mannheim and Berlin. And we treated 144 patients here, treatment-resistant depression patients. And yeah, this is going to be published in the next month, the results of this study. Yeah, then the augmented psychotherapy training. This is the last cohort in this training. If you look closely, you will see 3 Finns here in the group of, I think, 24 people. They just started this year in November. This is a 15-month professional training for mental health professionals. We will talk a bit more about the kind of admission criteria later. We've taught 4 English and 2 German language courses. And this has been developed according to the outcome-based education principles, which I'm going to present in a bit, the outcomes. But first, a bit of more definition. What is psychedelic therapy? What is it not? So sometimes people understand different things under psychedelic therapy. Here, I really want to just refer to the medical and psychotherapeutic use of psychedelics and other methods for inducing psychedelic experiences in the treatment of mental disorders. So let's say we use psychedelics to treat, I don't know, phantom pain in people with amputations. We may not necessarily consider that psychotherapy, yeah, or it's a different kind of psychedelic therapy. That falls outside of the definition that I give here, yeah, and there are also gray zone cases. So here we're only really speaking about the treatment of mental disorders. The acute subjective effect is a central part of the treatment. It's not a side effect. It's purposefully induced and used psychotherapeutically. The psychological and neurobiological effects are used in synergy, and the treatment is delivered by mental health professionals, so medical doctors, psychotherapists, and so on, and often in multi-professional treatment teams. But this is also important, that not every member of such a treatment team needs all the necessary competencies. Yeah? So there could be a doctor who takes responsibility for the pharmacological interventions and the medical aspects of the treatment, but the treatment could still be led by a psychotherapist who's a psychologist by training. And we can imagine all kinds of different constellations here. Yeah, and of course, I also only refer to legal treatments here. We're not speaking about underground therapy. Special features. So yeah, this is, I think, special compared to other psychotherapies. We really induce altered states, psychedelic experiences. We work with patients in extreme vulnerability and suggestibility. This brings special responsibilities and demands on competencies of therapists. Treatment teams I've already spoke about. The substances are not yet approved in many cases, of course. This is a very important point for today, that there are, compared to other treatments, yeah, if you look at, I don't know, antidepressants or, let's say psychotherapy, yeah, there are various reference systems that claim interpretational sovereignty over psychedelics and psychedelic experiences. There's not just the medical and psychotherapeutic view, there's also many others, yeah, just to give examples, psychonauts, countercultural perspectives, prohibitionist ideas, transhumanism, religious, shamanic, esoteric, you name it. Yeah. So the psychedelic therapy is really developing in a field of also tension and competition between different reference systems. Yeah? And I think this poses challenges for psychedelic therapists and for the development of psychedelic therapy in general, and it should also be reflected in the formulation of competencies that are needed here in this psychedelic therapy. Yeah, and there is this polarization between hype and moral panic, of course. So yeah, let's speak about the competences that we formulated for APT against this background. So first of all, there are some practical competencies: cooperate, communicate with colleagues in multi-professional teams in healthcare institutions. This is, among other things, this is very much about language, yeah? using a professional language to talk about psychedelics, psychedelic therapy, psychedelic experiences. To prevent and mitigate adverse effects of psychedelics, harm reduction, of course. And then 9 to 12, this is really just the standard procedure of psychedelic therapy, from screening to preparing patients to the dosing sessions where we induce and accompany psychedelic experiences in appropriate settings, of course. We have to know what that means. And in the end, integration and transition to the post-treatment phase. So this is the practical part. And I don't want to spend too much time here with the practical competencies. I think all of these could be discussed at length. But I think it's more interesting to look at the basic competencies that we formulated. And of course, we will look at the practical competencies again when I show some case examples. But let's come to the basic competencies. So the first one is, this should not come as a surprise now, to apply psychotherapeutic concepts, methods, and attitudes in psychedelic therapy. So this reflects the idea that we think psychedelic therapy should be conceptualized as psychotherapy, and that psychedelic therapists should work as psychotherapists and not as, let's say, shamans or I mean, they can, but not when they provide psychotherapy. So, as shamans or as spiritual teachers or guides or so. A question that's often asked, okay, so what psychotherapeutic concepts, what methods, what attitudes? And many other programs answer this with specific therapy schools. It should be ACT, or it should be psychodynamic therapy, or internal family systems, or something like that. And we take a different approach. We take a research-based approach, and we look at what psychotherapy research has to say. And that's a really, I would say, integrative view of psychotherapy. Of course, many different forms of psychotherapy are effective, and that's probably because they tap into the same underlying general change mechanisms. So that's the point of view we try to convey in this training. And it's also a chance for people to, because the participants have very different backgrounds. They come from all kinds of therapy schools, and developing a common shared understanding of the change mechanisms and of the therapeutic process. It really helps us also learn from each other, the people with different backgrounds, and make use of the diversity of their trainings in psychotherapy. The second outcome, so understanding the scientific, there are some basic scientific competencies needed. You need to be able to follow, of course, the state of psychedelic research. You need to be able to have a realistic understanding of the potential therapeutic but also harmful effects of psychedelics. This is a dynamically evolving field of research, so you really need to be able to follow this. Medical competencies, of course, and foundations of psychedelic therapy. So, of course, there's always, when there's pharmacological interventions involved, and there has to be a medical doctor, a physician who's responsible for that. And they need specific knowledge, of course, about psychedelics and psychedelic therapy, indications, counterindications, side effects, interactions with other drugs, and so on. And then the last one here, these competencies you notice already, they're quite broadly formulated. The philosophical foundations of psychedelic therapy. So why is this necessary? So as I've said before, the psychedelic therapy is developing in this field of tension between all kinds of reference systems. There's not only psychotherapy, medicine, there's also neo-shamanic, esoteric. Not to judge about these, but what I'm trying to say is that they're often incompatible with a scientific, medical, or psychotherapeutic view of psychotherapy or of this treatment. And what happens when people are, when treatment, let's say therapists are overtaxed or overwhelmed by experiences of their patients or by their own professional self-experience, in terms of ontology, epistemology, when they can't make sense of this, then they often turn to epistemically questionable belief systems to make sense of their experiences or of the experiences of patients. And with that comes the risk to develop an exceptionalistic understanding of psychedelic therapy. Then people very quickly come to the position that, oh yeah, well, the rules of the normal rules of psychotherapy, they don't really apply here because this treatment is so special and so sacred and so on. Yeah? And then exactly that is, I think, what brings us the problems, the transgressions, yeah, for instance, that we've seen in the MAPS trial. I think this can be traced back to psychedelic exceptionalism and also actually the fact that the first wave of psychedelic therapy and research in the 20th century, that was unsuccessful and that it led to a prohibition. That can also be understood as a consequence of psychedelic exceptionalism. So, yeah, to really treat the philosophical foundations and discuss philosophical aspects in the therapy training is really necessary to make sure that the therapist can consequently, yeah, and consistently act as a psychotherapist, yeah, and not as something else. Yeah. Yeah, we need to understand the diverse history of psychedelics. We cannot just say, I'm not interested in shamanism, yeah, because I'm a psychotherapist. Yeah, I'm not interested in religious or spiritual ideas because what I do here is just medicine and psychotherapy. That doesn't work, yeah, because this field exists. There is lots of tension. Patients, of course, they come with all kinds of ideas. Yeah, they also get in touch with other reference systems about psychedelics, and yeah, it would be unwise to just ignore this. So we really need to know, yeah, what are the different reference systems of relevance? How do they work? What language do they speak? And only then can we understand really the expectations and the experiences of our patients, and we can look at their relationship to to psychedelics or to psychedelic therapy or to the diverse reference systems. We can look at it through a resource and a problem perspective, yeah, to look at the positive and the negative, potentially problematic side of these things. Yeah, complying with legal requirements, of course, that's shouldn't I shouldn't have to explain this a lot, and address ethical challenges. Yeah. Another thing is to really, this relates also to the second point, to there are some things about psychedelic therapy, of course, that you see very rarely in other psychotherapies. Yeah, let's say a patient has what could be called a mystical experience, and then develops an intense desire to and interest in spirituality and topics like that. Yeah, and we need to be able to understand this process and to address it in psychotherapy, not from of course, not from a position of a spiritual teacher, but from a position of a psychotherapist, to look at it as a potential solution or a potential problem or both. Yeah. So in order to do that, we need to incorporate, yeah, and to understand and incorporate these existential aspects, mystical experiences, but also other experiences related to, for instance, to death and birth and things like that. Yeah, and the sixth one, I think, yeah, this is, as I said already, is very much discussed in the field. Should people have a psychedelic experience or not, or many, or how many? We say I should also say this. We don't require psychedelic experiences when somebody applies for the training. We offer self-experience with psychedelics in the training, with ketamine and with breathwork. a lot of people have what qualifies as psychedelic experiences with these methods. We also don't require people to have ketamine in the training. Some people say they don't want to because maybe they have decided to, in principle, not use any substances for various reasons. Yeah. So I don't think this is necessarily a problem because people can also learn from other people's experiences. Nonetheless, yeah, for most people, it's really helpful to have these experiences. But of course, it's not that people should have just as many experiences as possible, or as therapeutic experiences as possible, but rather this is about understanding the develop an understanding of the context sensitivity and the context dependence of psychedelic experiences, and yeah, to develop a learning-oriented attitude to self-experience. So these were the basic competencies. Any questions so far? If nothing is really pressing right now, I could go on to show some case examples to make it a bit more palpable. So this is the prototypical course of a psychedelic treatment. Yeah? Referral, screening, treatment planning, preparation, dosing session, integration. Then maybe there is a loop, yeah, more preparation, dosing session, more integration. And then at some point the treatment is ended, and then there's maybe some aftercare. So let's walk through this process with some examples. So here's a patient. We're now in the stage of screening and treatment planning. So the 57-year-old patient comes to the practice with depression for a very long time, currently in a moderate episode. Yeah, they have tried antidepressants, and they're still on an antidepressant, but it doesn't help or hasn't helped much. They've tried psychotherapy, that has helped somewhat, but yeah, depression is kind of still there. They have some somatic conditions. They also describe a family history, like the mother, sister was kind of strange and paranoid. She was in psychiatric treatment. And the patient tells us that the marriage, they're married, but they're currently being divorced. Yeah. So I think this is a good example of why we need these competencies here. First of all, it's clear, yeah, that we need a medical specialist here. Yeah, we cannot, without a medical doctor, we cannot decide whether or not this person could be given a psychedelic, or what kind of psychedelic, while the person is on an antidepressant. Is that a problem? Do we need to taper the antidepressant out? If so, how? Yeah, it's very clear. Yeah? We need a medical doctor with specific knowledge about psychedelic medicine. Yeah. We need to cooperate, of course, with such a person, perhaps also with other people who are treating or have treated this patient. We need to. This is, of course, the screening and treatment planning is always involves an aspect of preventing harm, and yeah, of course, we're at screening patients and planning treatments. So next situation, preparatory session. So this is a different patient now. By the way, these are all real treatment examples. This is another patient. First preparatory session with psilocybin. The patient says they want to achieve ego death with psilocybin and leave anything negative behind. So this is their kind of their initial intention for the treatment. In this case, a study treatment where we have very little time to prepare the patient for an experience. And they also mentioned that they're kind of afraid of the upcoming session. They asked, could there be spiders? What if spiders show up? Yeah, and I don't think I could handle that. So, and they also asked me, have you tried this substance yourself? So this touches very different competencies again. First of all, of course, we need to have psychotherapeutic knowledge here. Yeah? We need to be able to judge from a psychotherapeutic point of view, is this here an intention that is useful? Or could there be would it be useful to elaborate an intention that is more approach motivated, that is more likely to lead to an adaptive attitude in the dosing session. How to deal with the fears of the patient. This also needs a psychotherapeutic competence. The self-experience, of course. All of this important when preparing patients for psychedelic experiences. Next situation, dosing session. So different patient, again, this patient has a what would be called in the literature a challenging experience. They get a bit anxious and really afraid, and in the end they have something even like a panic attack. They take off the headphones and eye shades. They report frightening imagery and bodily sensations. So what do we do? So again, of course, this is a situation where it seems like I have to if I have a colleague in the room, I have to be able to cooperate with them. We need to understand both what we're doing. This is a situation that is relevant to the prevention of adverse effects. Actually, preparation is important here too, because the whole situation it is very different when you're prepared for it. A patient who has been thoroughly prepared for an experience. We can do different things now. With a patient who has been prepared, we can work in this situation very psychotherapeutically. And if they have not been prepared, we have to do different things. And then, of course, what to do? Should we immediately give the patient a benzodiazepine, or should we distract them, try to make them pay attention to something more cheerful? Should we change the music, or open the windows, or I don't know, so many things that you could think of, or should we, and this is where the psychotherapeutic competence comes in, should we help the patient maybe approach the problem rather than avoid or run away from it? And then, of course, we can use all kinds of psychotherapeutic techniques to try to make something positive and valuable out of that experience, and not just mitigating it. Next example. So this is an integration session, different patient. The patient tells us about something that could be called a mystical experience, intense positive feelings, unity and connectedness, even with the universe and God, and an impression to have had access to some absolute truth that is difficult to describe with words. Of course, this is a very positive event from a scientific point of view. We know that these experiences are predictors of long-term treatment success. Now we need to do something to integrate, or maybe we don't. I don't know. That's already an interesting question. Again, here to integrate this experience from a psychotherapeutic point of view, understand that it would be good that to make something out of this, to derive new approach motives, to help the patient somehow translate this into need-fulfilling experiences in everyday life. This is what we should do as psychotherapists. It's a completely different role when you're, or you have completely different goals when you're a spiritual guide or teacher here. So that would be a very different. You would also use very different strategies here in this situation. You need to be able to understand, of course, and incorporate these aspects while still acting from a psychotherapeutic stance. Another example from integration session. So this patient reports a disturbing experience from the dosing session. This is from the literature. So this patient had a vision where they're lying in bed, and then the mother is trying to suffocate him with a pillow, and it felt very real. And now he wonders if this could be a repressed memory of a real traumatic experience in his childhood, and now he's considering taking part in an ayahuasca retreat to get to the bottom of things. Yeah. Yeah, this is a very, as you can see, is a very complex situation, of course. Yeah, it seems like this is a situation where we have to, it's relevant what we do, yeah, in the sense of preventing harm. It also seems like a situation that that needs to be an experience that needs to be integrated, and where there is some potential also for therapeutic progress. Yeah, and for that, of course, again, yeah, we need to have a psychotherapeutic stance, and not some stance, let's say, of a person who's trying to find out the truth about the past. Also, yeah. We also need an understanding of the science of how memory works. What is it possible to reconstruct repressed memories accurately in psychotherapy? Yeah, this is something that we need to know, yeah, if we want to work with psychedelics, because these experiences are not rare at all. Yeah. We also need to understand the reference systems that this person will encounter if they read books by, let's say, Gabor Mate or so, yeah, or if they go to an actual ayahuasca retreat, the kinds of models, yeah, that the patient will maybe already have encountered here or will encounter in the future. This is very relevant, yeah, to our psychotherapeutic practice. Yeah. And then, of course, there's the ethical challenge associated with the situation when a patient says they want to use psychedelics outside of the clinical setting, perhaps illegally. Yeah. Aftercare, different patient. Let's say the patient wants to start psychotherapy after the treatment with the psilocybin, and now they're unsure whether and how they should talk about her experiences with psilocybin in their psychotherapy. So here again, yeah, it's important that we, for example, we're able to write a treatment report that is not written in ununderstandable psychedelic language, but that is understandable for a psychotherapist who has perhaps never heard about psychedelic therapy. So yeah, that's another important example of the necessity to apply psychotherapeutic methods, concepts. Yeah. Let's move on to the APT program again. Some pictures. So this is a training that balances these different aspects: practice, theory, mentoring, supervision, self-experience, feedback, evaluation, and it's something that seems important, the professional network that people develop when they take part in such a training. So here's a timeline for the training. It's 3 intensive weeks in Berlin, each for 7 days, over 15 months. And at the same time, in parallel, there's an ongoing online curriculum with lectures, mentoring sessions. This is a bit like clinical supervision, a journal club to engage with scientific literature and meditation training. Here, I wanted to show you a typical timetable for an intensive week, but I didn't. I forgot to paste it here. So I wanted to show a timetable. Maybe I can, after the talk, I can quickly look for it, and then we can still look at it. What I wanted to show here is the interweaving of theory units with practical units and self-experience units. So we're always going from one to the other in the intensive weeks. Yeah, maybe we have some time to still look at it later. Yeah, this I was told would be of interest today. So who can be admitted to this program? Psychotherapists and medical specialists with dedicated psychotherapy training. So this is psychiatrists and doctors in psychosomatic medicine. So these people are admitted, these two groups, and they're also certified to lead therapeutic teams. Certified. This is a private certificate, of course. It's not a state recognized certificate, but we train them to lead treatment teams in augmented psychotherapy. And the other groups here, they're also trained and certified as to work in multi-professional teams. Yeah. So this could be medical specialists with or medical doctors without a completed or additional psychotherapeutic qualification. It could be anesthesiologists. Of course, yeah, these are needed for certain kinds of psychedelic therapies. Addiction therapists in Germany, for instance, addiction therapists often have a quite intense psychotherapeutic training. They're often very experienced psychotherapists, but they're not psychologists in many cases, but often have a background in social work. Yeah. And then there are complementary therapists, so people who do art therapy, music therapy. We would usually, very rarely have we had an application from someone who fits the general application criteria and is let's say, an art therapist. Usually this is for people who really work within the healthcare system, let's say, as part of a multi-professional team in a psychiatric or psychotherapeutic clinic. Yeah. Social workers already talked about. Psychiatric nurses, of course. Yeah. In the last course, for instance, we have a psychiatric nurse with a lot of psychotherapy training. Yeah, there's also some informal admission criteria, of course. So we pay attention to an understanding and interest in psychotherapeutic processes. People should understand the scientific method and show an ability to think critically. We look at, of course, because this is psychotherapy, we look at self-reflection skills, professional communication skills, the ability to explain psychedelic therapy to third parties. So this is often a question I ask in interviews. I've done around, I don't know, 300 interviews maybe with participants. Awareness of problematic aspects of psychedelic therapies. Respect for the need to follow legal and ethical practices. This should be clear, I think, but it's you would be surprised how many people write in their applications that they are underground therapists, or who tell us this in an interview. Yeah. Yeah. Then there are informal exclusion criteria. So yeah, people who have uncritical attitudes towards ideas that can be evaluated as pseudoscience, charlatanry, conspiracy theories, or esotericism. Yeah, maybe one example of this is really interesting, of psychedelic exceptionalism. I interviewed a man who applied for the training and who's a psychotherapist with various trainings in psychotherapy, psychodynamic and cognitive behavioral training. He's also has his own training institute. Yeah, he trains officially an officially state recognized certifying training institute where he trains psychotherapists. He's also a supervisor and a trainer of supervisors. So you really, it's hard to be more, let's say, more established in the healthcare system as a psychotherapist than this man. But when I was doing the interview, I had the impression that he has two identities, yeah, and one is the identity of a psychotherapist, and at the same time, he sees himself as a shaman, and he was always switching between those different reference systems, and it was clear that he understood psychedelic therapy as a shamanic therapy. Yeah, of course, illegal therapy practice. This is an exclusion criterion, rejection of conventional medicine or psychotherapy, and then political or religious extremism. I think we had one or two applicants who were not excluded from the training, but not admitted because of things like that. Yeah. Yeah. I don't know how much time I have used. Oh, I have used almost an hour. Okay. Great. Yeah, thank you for your attention. Looking forward to discussion.
All right. Thank you, Max, once again for an interesting and informative lecture, like you did as well in Turku, to keep up the quality. So what's going to happen now, we're going to move to the Q&A section. And for you guys who haven't been attending to seminars before or webinars before, you can ask questions. And if you want to ask them yourself, we unmute your mic when it's your time to ask the question. And if you don't want to ask it yourself, you can just write that at the end of the question. So I'll read the question for you. And you can also select the option to submit your question anonymously as well. And English is preferable, but if you want to ask it in Swedish or Finnish, I can do my best to translate from both languages. But let's get on to that. I see that we already gotten three questions here. And one more thing, you can upvote questions that you want to see being answered like earlier, and they tend to get chosen a little bit before as well. But it's only 3 here, so I'll go right away from the first one. So this is from an anonymous attendee, so I read it myself. What's your professional and personal opinion about underground psychedelic therapists? If people are taking psychedelics anyway, isn't it better that they do it with an experienced guide? And then a second question is finally, how would you advise people doing this work?
So the first question, what do I think about underground therapists?
Yeah,
I mean, that's formulated in a way that it's directed at the individual. So I can talk about underground therapy. I think we're beyond if we've ever been there, we're now beyond the stage where underground therapy is doing. Perhaps, I mean, maybe start differently. Of course, there are individuals. I've also met individuals who've benefited from underground therapy, and I think that should be acknowledged, of course. And it is a possibility that people have positive experiences in underground therapy. But on the other hand, I think underground therapy right now it's a danger to the broader establishment of psychedelic therapies in the healthcare system. I also believe that it's very, very difficult or even impossible to provide underground therapy in an ethical manner, because there are so many complex problems that arise from working in illegality. The therapeutic relationship and the therapeutic frame, it just cannot exist in illegality, because it creates a relationship of dependency between the therapist and the I'm not sure if I would even say the therapist. Let's say the provider, and the client. So the client, the provider depends on the client not to complain, if something goes wrong or so. So very often, typically in underground therapy, people do all kinds of things to protect themselves. Like, for instance, they start all kinds of dual relationships with patients. Things like they also become friends, or they start very long-term therapeutic relationships that create dependency and things like that. So this is very commonly seen. There's no oversight over what people do. So yeah, I don't want to judge on each individual that's providing psychedelic therapy in the underground. I would also say there's a difference between sometimes I should add, that we have to be clear what that means. When I mean underground therapy, I mean also a transaction, an economic transaction where people take money to treat people illegally with psychedelics. That's different from using psychedelics for therapeutic purposes on your own or with friends or with a befriended therapist even. Yeah, that's a different thing. Yeah. So yeah, but I think I would also be interested in other opinions. I don't have the maybe the final answers to these things. But our stance is very clear. We don't train underground therapists. And yeah, we also pay a lot of attention to the potential dangers of underground therapy. And we see them in patients also.
All right, thank you. We move on to the next one. We touched it a little bit beforehand when we were talking as well. This is like a country specific problem where you don't have universal titles. But so an anonymous attendee has asked, can you elaborate your thinking about the relationship between conducting psychotherapy and being a psychotherapist? What the latter precisely refers to differs from country to country, and to my understanding is a very different thing in the US and say Finland. Here, only a person with certain credentials, for example, an MD or a psychologist, can train to be a psychotherapist. In your context, can just a psychologist or just an MD conduct what you refer to as psychotherapy?
Yeah. Good question. So yeah, this is also a question that's difficult to answer in an international context. Yeah, and we also see that. So we do this training in English with international courses, and we also do it in German with just German speaking people. But then people also come from Austria and Switzerland. And of course, each country has different regulations. So when we say a psychotherapist, a licensed psychotherapist can be certified to lead a treatment team, then what does it mean really? Yeah, it's not so simple to answer. In many cases, we have to look very closely at what that means. Usually, I would say if somebody is from a country like Finland or a European country, then it has to be a psychotherapist or a medical doctor with several years of psychotherapy training. Yeah. In other countries, for instance, let's say we have someone from Brazil. Yeah, it may be a bit different. Yeah, people can be credentialed, licensed therapists. They can work with insurance and stuff like that, but they don't have the exact same. It's hard to compare then. Yeah, so it's a bit of a difficult decision. So we also pay a lot of attention to the informal criteria here. Yeah. And then many people who we train also are therapists who are still in training. Let's say a medical doctor with, let's say a GP, yeah, a general practitioner, who is currently in training to become a psychotherapist. And they do this, and at the same time, they already start this training. Or people who are in there, who are medical doctors, and who are now in their specialization, let's say in the last year or second last year as psychiatrists. We would also, of course, train them. Yeah, yeah, but generally, I say we really train treatment people to be members of treatment teams. So not everybody in this team has to be a full-blown psychotherapist. We have people in the training who, let's say, who are anesthesiologists. Yeah? Usually they have a strong interest in psychotherapy, but not a lot of training in it and not a lot of experience. And then for them, this is the first time they really get in touch with psychotherapy. And they often develop a desire to learn more and to read a lot and to practice and things like that. Yeah. But it's interesting. It's an interesting experience because yeah, we thought, is this really possible to train people who have such different backgrounds in one course? Shouldn't there be different trainings for all of these groups? But after 6 courses, we would say, no, it's really, really, really very valuable to have people with different backgrounds in the course because everyone brings in their perspectives. And then on the other hand, also psychotherapy, yeah, it's also it's hard to be a psychotherapist. You have a lot to learn, but to be part of a psychotherapeutic team and to understand and to work together with a psychotherapist and understand what they do and contribute in a valuable way to their work, that's not that hard. You can learn that as an anesthesiologist. Yeah? And then, for instance, so what this person may do, they do the training with us, and then they team up with another person from the training who's a psychotherapist, and they start treating people with ketamine-augmented psychotherapy. Yeah. And they become a team together. And the anesthesiologist is maybe only there for a part of the sessions, just for the dosing sessions, and maybe sometimes for a preparatory and integration session. Yeah. Just to give an example.
All right. The next one, an interesting question as well. Have you received criticism or negative reactions to your approach to training or who you accept in the training? If so, can you talk a bit about some of the most relevant ones?
The most irrelevant? No, the most
relevant.
The most relevant. The most relevant. Well, I mean, sometimes people apply for this training who clearly don't fulfill the formal criteria. People even pay. We ask for a small fee for the application because it takes a long time to review the applications and to do the interviews and so on. And we also want to discourage people who are completely unqualified to apply. So, but still, some people they pay this fee without really reading the criteria or it's and then sometimes people are really hurt by hearing that this is exclusive in a way. But it's not very often. It has happened on occasion. Usually people are very thankful. Like, for instance, what happens a lot is that we or people who could be qualified, but sometimes I tell people maybe it's good to wait another 2 or 3 years and get more. Let's say if a young person just training to become a psychiatrist and they've not started with psychotherapy, sometimes we would tell them it may be better. You may benefit more if you start in 2 or 3 years. People are usually very thankful to have this kind of exchange and develop a kind of career perspective together. Negative reactions. I would say there's one group of people in Germany, the naturopaths, naturopathic healers. This is a system in Germany that is a bit besides the medical system. So you can easily become licensed as a naturopath. And naturopaths, they do all kinds of things. Also works psychotherapeutically without being licensed as psychotherapists, but they can offer this to paying participants, patients. And I assume many naturopaths are talented psychotherapists. But we don't know, and they're also really not part of the medical or of the healthcare system, and some of them have reacted negatively to hearing that we cannot train them in this training. But it's relatively rare.
All right, thank you. And the next one. I'm going to also ask another question regarding the next question as well, but I read out the question first and you can answer that in. Please talk a bit more about why and how it becomes a problem when a psychotherapist applying for your training program thinks that they are doing something like shamanic therapy. The answer might feel obvious to most, but it's still probably worth articulating it.
Yeah, good question. So what does a shaman do? It depends, of course. Yeah, of course, if somebody tells me, and by the way, very often people in their application, they write something like, "I'm very interested in shamanic practices," or "I would like to integrate shamanic methods with psychotherapy." Also, when I read that, it's not that I delete the application or don't invite the person, but rather, of course, what we do is we ask what do they mean, and we try to develop a shared perspective. And very often it's very useful. Actually, very often people have the idea, people have their own experiences in shamanic contexts, and they noticed that there is a lot of wisdom, of course, a lot of practical wisdom in the shamanic traditions, and maybe they have had fantastic therapeutic experiences. And then what I try to do is we try to find out whether this can be translated into a psychotherapeutic perspective, or if it's really incompatible. So incompatible would be so the role of a shaman, yeah, is usually to make contact to some spiritual entity, yeah, some supernatural entity, and yeah, I would say that does not that does not go together with the principles of psychotherapy. It's a direct contradiction to what psychotherapists do. Yeah, it's yeah, that is not to say that we cannot learn a lot from shamanism and that we shouldn't engage with it. Yeah. But a psychotherapist should rather yeah, help be transparent also, yeah, about what they do with the patient, be able to explain what is going on, and not yeah, use some supernatural connection for these things. I'm not against, I have to say, I'm not against shamanism. I've met wonderful shamans. I just don't think that's the way to integrate psychedelic therapy into the healthcare system. It won't work.
And my question regarding that as well, I would like to hear a little bit about your view on the MAPS decision to choose words like inner healing intelligence, for instance, something that they've been criticized for later on, that they kind of brought this not directly a spiritual dimension, but kind of like using that word has some associations for a lot of people, even though that's how a lot of people experience it, that something inside you knows what to do.
Yeah.
Do you think it was a mistake that MAPS used these kind of terms in their actual treatment manual? It's not just something that they think about it, they actually put it in the manual and having it as like a central word for the whole treatment.
Right. Yeah, that was probably strategically not so well thought through. Although in hindsight, it's always easy to say you shouldn't have done this or shouldn't have done that. But yeah, so the concept of an inner healing intelligence, I think we can trace it back to Jung, to Jungian psychotherapy. It's also very heavily used in the so-called transpersonal psychology, which is, yes, we have to say that, yeah, that this is regarded by mainstream psychology as a fringe discipline. Yeah, it's not considered a proper scientific psychology. Yeah, it conflates psychology with different kinds of spiritualities, and it's perhaps not a very good fit for if you want to convince people who regulate medicines, and who are already find it difficult to engage with something like psychotherapy. That's already for biomedically oriented people, that's already a lot. Yeah, and then on top of that, to have such a yeah, let's say epistemically questionable reference system is maybe not the best choice. That being said, of course, the inner healing intelligence, I wouldn't say that it's necessarily a bad concept. Of course, it can be a very powerful metaphor, and also it can be, you can make connections to concepts that are very established in psychology and in psychotherapy. Yeah. So the whole idea of course of homeostasis, yeah, or Antonovsky's idea of salutogenesis, yeah, or the model that we use, Graves' model of general change mechanisms. Yeah, Graves speaks of a consistency principle. Yeah, so there is a natural tendency of the organism to strive for consistency between the biological and psychological processes, and the therapists in that view is just kind of trying to remove barriers to that. Yeah, and that's very, I mean, yeah, that's like, like when a medical doctor cleans a wound and then it heals itself, we can apply very similar concepts to psychotherapy, and we don't have to leave a scientific or let's say enlightenment worldviews in order to incorporate that idea. The thing is that MAPS didn't try to. Yeah, they just referenced Groff, and they didn't try to make it a psychological concept, but they used it as a spiritual concept, and that is the problem.
Yeah. All right. Thank you. The next one. What is your view on nose-administered ketamine Spravato and IV ketamine sessions for applicability, treatment results, and cost?
Yeah, good question. So yeah, costs I think is clear. Spravato is very expensive. I have no experience with treating patients with Spravato with esketamine. In our clinic, we use racemic ketamine. We use it as infusions because in our view, this is the least risky way to do it, and it's also yeah, for several reasons. We have to work off label, of course, when we do this. And when you work off label, you have to think very carefully that what you do is justifiable, yeah, in terms of the patients that you treat, the indication and so on, yeah, but also the application of the substance. So we stick very closely to recommendations that you can actually prove exist and that have good scientific evidence. Yeah. So yeah, that was my answer in terms of cost and yeah, the practical issue. Yeah. And then also, of course, yeah, esketamine is less psychoactive, at least in terms of inducing altered states of consciousness and states that would qualify as psychedelic. Yeah. So when we use ketamine the way we use it, people often have experiences that are, as a therapist, really, I would find it very difficult if I were blinded to distinguish between those experiences and the experiences that someone has during a psilocybin session. Yeah. So this seems to work very well with racemic ketamine, with nasal and esketamine. It may be much more difficult to induce such experiences. But I don't know. I'm not an expert on esketamine.
Yeah, we started also like providing Spravato, like nose or nasal ketamine to some of our patients. So, and our experience as well is that it doesn't induce any altered states. People get a little bit like feeling sick, a little bit dizzy, but it's used in an anti-depression kind of a way. So you kind of like have repeated use in order to get kind of like this anti-depression effect rather than actually like realizing something about yourself in that sense. So yeah. Next one. What do you think are the most important things that clinicians who are not that familiar with psychedelic therapy ought to know about psychedelic therapy and psychedelics? Perhaps especially in the context of how psychedelics are being talked about in the current media discourses that they might be familiar with.
Very good question. So what's the most important thing? So I would say something that really strikes me is how difficult it is for outsiders, yeah, for people who are just developing an interest in psychedelics, to be oriented in the discourse. So as I said, yeah, there is this tension, there are these different reference systems. You read something about psychedelics that's from let's say, a psychedelic advocate, yeah, who wants to get psychedelics regulated and admitted. Or you read something from Guy Goodwin, yeah, who has a kind of, who wants to portray psychedelic therapy as a biomedical treatment that has nothing to do with psychotherapy. Yeah, then you have psychotherapists, of course, or you have prohibitionists, yeah, who like many people in addiction medicine, yeah, they've been trained to tell people that psychedelics are dangerous, yeah, and they will use different words. They will, for example, usually say hallucinogens and not psychedelics. Recently, a paper was published by psychotherapy researchers, yeah, that criticizes the state of psychedelic research. I think that's very important that people from the outside come and take a look at what people in psychedelic research are doing. And they were pointing out some relevant problems. And at the same time, it was very clear that they only just had started to engage with the topic. And they used words that make it clear that, oh yeah, this is where they're coming from. And they were talking all the time about hallucinogens. One quote is, psychedelics, comma, the lay term for substances normally classified as hallucinogens. Yeah, so this is the kind of language. And when you read this, I think this is what I'm getting at is you need to know to be oriented in the psychedelic field, in psychedelic research, and more broadly discourses around psychedelics. You need to understand that there are different reference systems, that there is a complex history, and that the different reference systems are associated with different kinds of language, and that a lot of the things that you see in the heated discussions on social media, yeah, with people who criticize psychedelics and people who are advocates and people who are more balanced, is that the people who are not familiar, yeah, with the different reference systems and with the different kinds of stakeholders, yeah, they have a very hard time understanding what's going on, yeah, and then they easily paint the field into black and white, yeah. So every psychedelic researcher is an advocate, yeah, and so on, yeah. That's the reality is much more complex than that. So I would say that the most important thing is to get to know the different stakeholders, yeah, their reference systems and the language.
Yeah, makes sense. All right. This is a personal question. So let's see. I'm over 50 years, a psychiatric nurse, a nursing teacher, solution-focused brief therapist, and interested in psychedelic therapy. What I have understood in Finland, psychedelic therapy is not really yet a choice. So the questions are: should I try to apply to your training, and what do you think when this therapy is normal legal psychotherapy choice for patients? I mean, am I retired before I can apply therapy to clients in Finland?
Yes. Oh, yeah. Wonderful. Yes. So I would love having more psychiatric nurses actually in the training. So please apply. Also, yeah, some things in the question. So the question, this is not available yet. When will it be available? I get this question asked a lot also in the interviews, and I always say, yes, it's true. Some of the things that we teach, like using psilocybin, are only at the moment only available in compassionate use or in clinical studies. But a lot of the things that we teach are already available. Yeah, so the ketamine can be used almost anywhere. In Finland, it may be a bit more difficult than in Germany, and in some countries it's harder, in others it's easier. But that is already really available. Yeah, it's not a substance-focused training. Yeah, we're not. This is not a ketamine training, although we use ketamine for the self-experience, and we draw a lot from our experience with ketamine. It's more an experiential training, and then there are different methods to use. So ketamine is already available. Non-pharmacological methods are already available. Also, of course, that's a great thing. You don't need a medical doctor, yeah, to apply something like breathwork. So these things are in part available. So I would say let's look at it in a differentiated way. And then, of course, it's still we need to have a realistic understanding of when will the other substances be available. Yeah? And psilocybin, MDMA. A few years ago, a lot of people would have said in 2025 we will have MDMA, yeah, because they thought that MAPS is going to march through. And right now, yeah, maybe it will. With MDMA, it will take much longer. The Compass phase 3 study, I don't know if that's going to be if it's so sure that they get it approved. Maybe not. Yeah. So there are. We're preparing a phase 3 study. It could, if it all works out, it could be in 3-4 years. Yeah, but it could also not. So I don't want to make any promises in that regard. I would say. Usually, I tell people when they make it their decision very dependent on a specific substance to work with. I tell them that then it's better to wait, of course, yeah, because we cannot. I don't know, yeah, if you will ever be able to work with psilocybin outside of a clinical study setting. I would say, what you get if you start now, it's more like a new whole box of methods, a different way of working with experiences. People often come out of the training with a much more experiential way to do standard psychotherapy. A lot can be learned, yeah, from bringing together psychedelic methods and non-psychedelic methods. And then also, I think what's important is, I would also say it's something that the participants have in common is the kind of a pioneering spirit, yeah, to say, okay, I don't exactly know how I'm going to use this, but we'll find a way together. And that's what the networks we build, yeah, we use these networks for. In Finland, for instance, in the first group, we had 2 Finns. In the second group, we had another 2 Finns. And in the third English group, we have 3 Finns now again. So, I think 2 or 3 of the Finns have already come together and are setting something up together in Finland with ketamine. And yeah, it's if you're not willing to be a pioneer in some sense, then it's better, I think, to wait and let others do the pioneering stuff and then join later, yeah, which is totally fine.
Yeah, exactly. Probably like the FDA's decision not to approve MDMA was kind of a hype killer as well for a lot of people. So I think like it slowed down the kind of like the push towards moving forward as well a little bit, which might be also good for the field in the big run. Who knows?
Yeah.
Hard to tell.
There is a very also, I like looking at things always from 2 sides, of course. I mean, I had mixed feelings, yeah, when this decision was made. But it's also very easy to see the upsides of it, yeah, to say, hey, let's try this a bit more slowly now and perhaps more thoroughly, and let's all learn something from the mistakes that have been made.
Yeah. All right. Next one as well. What do you say to people who are understandably wary of the medicalization of psychedelics because of the general suspicions that they have towards psychiatry, big pharma, with its actual profit maximizing over prescribing tendencies, the difficulty that modern culture and medicine has in treating mental health problems or supporting human flourishing in order to avoid such problems beforehand, fundamentalist scientism, etc. Don't know if I pronounced the last word.
Yes. Yeah. I like the question. Yeah, so of course, I think we will not solve many problems with psychedelics if we just introduce them into a system that is failing in many ways. Yeah. So I think, by the way, our healthcare systems in Europe have many functional aspects. Yeah. I think for Finland, I'm not very sure, but I think it can be said that in comparison to places like the United States, we're quite lucky, and many things are actually functioning. And those things can be augmented and improved with psychedelics. Yeah. And on the other hand, of course, you could say that there are, especially in the United States, you could think, people are introducing psychedelics. Who is this going to be for? Is it going to be only for rich people? Yeah, or is it going to be in the end non-hallucinogenic psychedelics that you have to take every day, yeah, and that have nothing to do with the psychedelic experience and so on. So yeah, I don't think psychedelics can solve all of these problems in the healthcare system, but we have to fix them ourselves. And there can be a bit of hope that we can learn a bit from implementing psychedelics, and that's on the positive side. Yeah. So I don't like the medical system being portrayed as totally broken or totally malicious or so, but it's really great that we have modern medicine and psychotherapy and hospitals, despite all the big pharma stuff and lobbyism and what privatization has done to the health sector. They're still, for many people, they're still associated with care and hope, and we should be glad that we have them. I'd like to say an anecdote, yeah, for when we did the episode study at Charité Berlin in the largest psychiatric hospital in Germany. We decorated a room for the dosing session, a normal hospital room, and the people on the ward there, they they were always curious what we're doing there. And then, of course, they would, when we didn't have a session, they would look into the room and they say, "Wow, this is such a..." And we didn't do much, right? I mean, of course, we didn't have that much money. We just tried to make it a bit nicer lights, some paintings, a little rug, colorful things, soft lighting, music. Yeah? And it was much more cozy then. Yeah. And then the people look at it and they say, "Oh, we want that too. Why don't we use all rooms like that?" Yeah. And I'd say, yes, of course. You don't have, it doesn't have to be a psychedelic room for it to be a nice room where you can actually feel comfortable. You know? So I think there is some hope that psychiatry or medicine in general can really learn something from psychedelic therapy. There was a paper, I think 2 weeks ago, about this that came out. I don't know by whom, yeah, but talking about this idea that many of the things that are considered unique for psychedelic therapy or really necessary for psychedelic therapy might also be helpful, yeah, in psychiatry and medical care in general. Yeah. So let's be hopeful, yeah, realistically hopeful.
Yeah, exactly. And I can also, to whoever asked the question as well, like I was surprised a few weeks back where we always get these new psychiatrists to our work as well to have this lectures as well, and there was one about psychedelics now, which is a big step, I think, where you have like the whole psychiatric unit providing education about these things, though they are not even legal yet. So I think you can see a slow change as well, at least in Finland, towards these things also at the bureaucracy, like at that kind of like a higher level as well, not just people talking at lunch breaks.
Yes. Oh, by the way, I'm posting I found the paper. I'm posting it here for everyone. Yeah, this is a paper, Beyond Psychedelics, Set and Setting in General Psychiatric Practice. I think this is worth reading. Yeah.
All right, thank you. And we have one question here, and to all the listeners or attendees as well, like ask questions. We still have some time left, so be brave. No stupid questions. So you can just go ahead and ask, and you can ask yourself as well. Then you can talk to Max, and if you want to have a response to your question or to answer as well. But anonymous attendee asks, or first tells you, "Thank you for the fascinating lecture. I understood from your speech that in psychedelic therapy there is an association between positive long-term treatment results and having spiritual experiences during the dosing session. Is there a very strong correlation between the two? Is it possible to try to induce this kind of positive experience without crossing the line between psychotherapy and spiritualism?"
Wonderful question. Yeah. So first of all, I mean, yeah, it's true that the association between mystical, or what is called mystical type experience, and long-term positive changes, it's one of the best replicated findings in psychedelic research, not only in psychedelic therapy, but also field studies, observational studies, survey studies, and so on. So there is something to it, of course. Yeah. The question was, does this mean, so the question is, what can we do, right, to create a context where these experiences are more likely to occur? I think, yes, yeah. But first of all, I would say that probably what is therapeutic about these spiritual experiences, it's not necessarily the spiritual quality, but other qualities that go along with them. Yeah. So usually when you read the patient reports, or when you talk to patients who have these experiences, they often find values in these experiences. Yeah. So they find new goals, things that are worth living for, things that give them hope. They also find that these experiences often connect them with other people, with themselves, with own values. And that happens not only in mystical experiences, but also in the context of other kinds of psychedelic experiences. So that this underlying, and I would say probably actually therapeutic thing about mystical experiences I would refer to as resource activation in psychotherapeutic terms. And that's the positive side of psychotherapy, right? Like developing positive views. Could be of the universe and God, could also be of your neighbors or your dog or yourself or something. And this, this is a larger context, yeah. So it doesn't have to be mystical experiences, but it is often mystical experiences. And now we could think, so maybe we should have the Buddha statue. I think that was the idea in Johns Hopkins, that they put the Buddha statue there because they might have thought, okay, we see the people who have the mystical experiences, they are better off. So let's prime this with a Buddha statue. Yeah. Yeah, I think you can try that. I think there are probably better ways and more effective ways to do that than a Buddha statue. My personal hypothesis, but I think it has to be tested, of course, is that the most important context aspect of the psychological context that determines whether or not something like a mystical or let's say a strongly resource activating experience will occur is the fulfillment of psychological needs. Yeah? That people feel that they're in a positive and safe relationship in the moment. Yeah. Or at least when they have cues to that. Yeah. Because some people that's very, very difficult. But at least, when they have a context that signals, okay, this is a safe attachment here. Yeah. Or a context that gives you orientation and control. Yeah. Where you feel like I have been well prepared. Yeah. And I decide that I'm here for myself. Yeah. And I feel like I'm the person who's taking the decisions here. Yeah? And then something like self-esteem, yeah, when you realize that the people around you are, they like you, they respect you, yeah, they value your perspective, and so on. Yeah? And then also things like pleasure, yeah, the basic need to be in an environment that's kind of pleasing, and so on. So these and to have pleasant interactions with other people. So these basic needs, I think, that they're also at the core of the mystical experience. They're intensely need satisfying experiences. Yeah. So that would be my short answer would be, let's zoom out from the mystical experience, realize other experiences have the same therapeutic qualities too. And yeah, we should indeed create a context that is conducive to these experiences. We can try with Buddha statues, but I think there are better ways and ways that have less downsides. Yeah.
All right, I'm going to ask one question in between, and then we have another one. I was wondering about because you said you accept people from different backgrounds to your training programs, and then coming to the question about different psychotherapy approaches. You don't have to have the right answer, but if you would have to choose with a gun to your head, which approach do you think most captures the essence of the experience? Would you be able to choose one, or I can allow you to choose two and you can mix them up?
Yeah, good question. I understand. I get this a lot, this question. I think sometimes it's easier to answer questions about psychedelics, yeah, or psychedelic therapy, if we remove the psychedelic from the question. Yeah, so let's just say psychotherapy. Yeah, what's the best psychotherapy? Right, that was your question. Yeah, because I think many questions actually can be that are seemingly specific to psychedelics can be answered by just removing the psychedelic. Yeah. So what is the best therapy? So I was trained as a cognitive behavioral therapist. In Germany, that's very different from the United States, where it's all about treatment manuals and a very kind of technocratic kind of psychotherapy, but it's rather integrative. In Germany's cognitive behavioral therapy has developed as an integrative school of psychotherapy that tries to adapt a lot from the other therapy schools. So maybe through that I'm primed to psychotherapy integration. And I've worked in therapeutic teams with people from different backgrounds, and we've trained people from so many countries with such different training backgrounds. I really appreciate the diversity, and I think it's really, really good to have these different approaches. And at the same time, it's important to develop a common model and a common language so that we can understand each other, learn from each other. I need to understand when I'm working with someone, I need to understand what they're going at. Yeah? Even if I don't have the in-depth psychodynamic training, I need to have an understanding of what's the purpose of what they're doing. Yeah? So in that sense, I think it's you can't say that there's a therapy school that's better. Let's look at it more from the other side. I think there are therapy schools that fit better with the individual person, with the patient, as well as with the therapist. So there are therapists who may be brilliant psychoanalysts, and they would really just suck at CBT. Yeah. So maybe it's a personality thing or so. Yeah? And then there are some patients who really benefit from ACT, where normal standard CBT didn't do anything or so. Yeah? So let's be flexible. Yeah.
Yeah. Sounds reasonable. And I think but I think psychedelic experience can be a little bit different than normal psychotherapy. And I think especially the transference and the projection, that the intensity of them can be really strong. I think whichever approach you take, you have to be able to see that. Yeah.
So, but good that you say that. So in the old literature, it has been pointed out several times, that it's interesting how the therapy school that somebody comes from, it always dictates what they find interesting about the psychedelic experience. Yeah. So the Jungians, they see Jungian material in their patients' psychedelic experiences. The Freudians, they see Freudian material. Back then, cognitive behavioral therapy was not such a thing. But of course, so when I was trained in CBT, and the first theory paper that we wrote is the learning to let go. So cognitive behavioral model of psychedelic therapy, and I was intrigued by, oh wow, what the patients experience or what I experienced, it's very kind of CBT-ish, right? So I also had this tendency, but with time, I think, that's just, of course, because we're trained to see these things. And actually, psychotherapy, like an integrative, comprehensive understanding of psychotherapy, it includes all these views. So transference, you're not, I would say, of course, it comes from the psychodynamic tradition, but of course any competent cognitive behavioral therapist understands what transference is, and they pay attention to it, of course. So I think, but again, let's be flexible, and try to be integrative and look at the big picture.
About the so far too oversimplified question about if the therapist should have their own psychedelic experience, do you have any hypothesis about what could be the mechanisms, effects that would enable one to become a better therapist after having their own experiences? Often as a psychologist, we see any personal life experiences or emotional experiences as a double-edged sword that can either foster your therapeutic skills or block them, depending on many factors, not least on how effectively you have been able to process it. It's the $1 million question that you get.
Yeah, the long question. So the first part was what would be the mechanisms, right, of improving your own capabilities through self-experience? Yeah, good. Yeah. So the reason I think we include self-experience in this training is to sharpen or to improve people's understanding of the context sensitivity, context dependence of psychedelic experience, and also of the longer term effects. So that people develop an understanding of I showed this model, right? This contextual model where you have this mediator, the experience, and then that's impacted by the immediate context, and that is impacted by the superordinate context. And we use this model when we have self-experience with breathwork or with ketamine. after we have an integration with everyone in the room. So people can not only learn from their own experience, but also from the experience of the others in the room. And then we have a sharing, and people are instructed to make connections between the different parts of the model. So I had this experience, and I think, or it seemed connected to what happened in the room in the other group, yeah, or what we did in the previous preparation session, or the mood I have been in for the last week or so, yeah. And then people often have the insight that two people in the room, they have group experience, they have completely different reactions to the same stimulus. Yeah, so this music, yeah, was for one person was terrible, and for the other was very good. Yeah, in quotes. Yeah, or for something that a therapist did, or that a self-experience instructor did, was by one person was experienced as intrusive and rude, and by the other as reassuring. Yeah, and so to really understand these connections, yeah, between the context factors and the experience and its longer term effects, that's something you cannot learn from one experience, of course. Yeah, and it's also not something. So you need many experiences, and I would say these don't have to be your own experiences. They can also be other people's experiences. They can be your patient's experiences or other people in the group. So yeah, I would say that's probably the mechanism, that people get a better understanding of how experiences come about. Yeah.
Okay, so we move on. We have time for, I think, like the last two questions, or if they are fast, maybe one more. And I'm going to read them in the order they came. So the next one, I might be able to pronounce wrong this one word that's in citation marks, but we'll see how it goes. What do you think about the relevance of psychedelic chaplains? I don't know, do I get that right? People who have special training for addressing spiritual or even religious questions that psychedelics might arise in the psychedelic therapy, or may be relevant for participants even before the psychedelic sessions.
Yeah, good question. So I think there's a whole program, right, for psychedelic chaplains. So I think this is just different from psychotherapy. Yeah, there has been a claim, some people have demanded that chaplains should be involved in psychedelic therapy by default, because psychedelic therapy is so conducive to spiritual experiences. And to deal competently with spiritual experiences, you have to be a spiritual teacher or guide, or some, let's say, spiritual authority. And I would say no, precisely not. I would say as a psychotherapist, you can deal psychotherapeutically with spiritual questions. That doesn't mean that people find all the answers and the spiritual answers that they look for, but that's then not the purpose of the psychotherapy. So it could be, yeah, that, let's say, somebody does have a spiritual experience, maybe for the first time, yeah, in a psychedelic therapy. I'm the therapist, yeah, and the person then develops an interest in these questions, and that they seek spiritual guidance, and that's fine, yeah, and they may seek that outside of the therapy. I may even, as a therapist, help them identify that as a desire, yeah, and then it may be a result of the therapy to seek spiritual guidance, yeah. But as a therapist, I cannot provide spiritual guidance. Yeah? I can only provide psychotherapy, and that means also to distinguish different forms of spirituality or spiritualities. Yeah, so there can be, of course, healthy forms of spirituality that are conducive to mental well-being, yeah, to need-satisfying experiences, to fulfilling social lives. And then there are forms of spirituality that are avoidant and pernicious. Yeah? And of course, I have to be able to make a distinction between those. Yeah? But I can't give spiritual answers to my patients. Yeah? And I would say, yeah, that we don't need a chaplain in the room. In the same way, some people, sometimes they have experiences about, I don't know, about giraffes. I don't need a giraffe specialist in the room. Yeah, I don't know. Don't want to. Nothing against giraffes, and also nothing against any spiritual tradition. But I think we have to keep things separate. Yeah. And of course, and I should also say, yes, of course, it should be. I mean, we have only spoken about psychotherapy today. What I just said, it doesn't mean that that chaplains and religious communities should not be able to use psychedelics in their spiritual practices. Yeah, that's a completely different question.
Yeah. And the last question, I think we're running a little bit out of time, but we already touched it. But if you have a few words about this, like for a minute or so, it's okay. But it's what kind of difference are there in the case conceptualization process when comparing traditional psychotherapy and psychedelic therapy? Is there a unique model for this, or just regular case conceptualization as one would do in an integrative psychotherapy process?
Yeah. So case conceptualization or case formulation, I would say, yes, of course, very similar. Depending on what your background is, you will do a psychoanalytic or a cognitive behavioral, or what we do in APT, what I teach just as an example. I don't want to change people's therapeutic orientation. I use a case conceptualization that is based on the change mechanisms model by Grave. Just a 2 pages sheet to take your notes on to get to help you develop a case formulation. And it's about approach and avoidance schemas and the person's basic needs and their usual coping strategies and defenses and so on. And then there's a kind of a model of the problem, a model of the predisposing factors, eliciting factors, perpetuating factors, and so on. Yeah, so that's the general psychotherapeutic case conceptualization that you would use in any psychotherapy, or you could use in any psychotherapy. But then on top, we have 2 more pages, also for the case conceptualization that are specific to psychedelic therapy. And the one is about the person's general relationship to altered states. This can be viewed again from a resource and from a problem perspective. Yeah. So if somebody has a meditation practice, this could be a strength that can be used in therapy. It could also be a problem depending on how exactly that looks. Yeah. Or the drugs the person has used, the ideas they have about psychedelics. Yeah. So I gave an example here about a patient who seems to believe for some reason that you can take ayahuasca to find out something about your past. And to identify the reality of a perhaps traumatic memory or so. This would go on that page. Yeah? And then the last page can be printed. Of course, this doesn't have to be done on a page. You can also do it in your head. Yeah? But the last page is one page to specifically look at one experience, to analyze one experience, to look at it from different angles. Also in this contextual model. And to analyze, for instance, which basic psychological needs have been threatened or satisfied in an experience, and then which change mechanisms can we identify? So is this a resource activating experience? Is this a problem actuating experience? Is it a clarification experience? Is it an experience of mastery? And that helps us analyze or understand the full therapeutic potential of an experience without ignoring certain aspects that might not be in the center of my therapeutic orientation. Yeah. So yes, I would say short answer: normal case conceptualization plus some add-ons that are specific to psychedelic therapy. Yeah.
All right, thank you so much for your time here and all the answers. Do you have any final words? We have 2 minutes left, but do you have anything you want to say before we release you?
Well, no, yeah, thank you very much for hosting this. I really I enjoy that we have so much time, because normally things can get so rushed, when we have 20 minutes to say something that is so complex as this. As we've seen, there are many aspects of psychedelic therapy and competencies, and want to talk about all of them and then have a thorough discussion. So I really enjoyed this. I'd like to to come back at some point if it's okay for you and
Of
discuss
course.
something else.
Of course.
Yeah.
Always.
Yeah. Yeah, wonderful. Thank you very much, and thanks for the wonderful questions. And I just looked through the list, and I think I saw 2 or 3 people that I know. Greetings, yeah, and also to anyone else. Have a nice dark time of the year. Yeah.
Yeah, you too. You too. All right. Thank you, Max.